Well, good morning, and thank you for joining us today. I'm Jeremy Nordquist, President of the Nebraska Hospital Association, and we are proud to represent the state's 92 hospitals and the 50,000 Nebraskans they employ. For the NHA and our hospitals, we have a North Star that guides us. We believe that wherever a patient lives in the state of Nebraska, they deserve access to quality care. And we have to work to make sure our rural healthcare providers don't have to choose between financial survival and delivering that quality life-saving care. That's why today, in partnership with the Nebraska Rural Health Association, we're releasing the Roadmap to Strong Rural Healthcare. The Roadmap is a state and federal policy agenda designed to protect and strengthen rural healthcare services. 2 years ago, as hospitals and healthcare heroes worked to regain their footing after the COVID pandemic, we released the first Roadmap to Strong Rural Healthcare. The 2023 Roadmap presented a policy agenda designed to rebuild our workforce, help hospitals stop the financial bleeding, and make sure patients could get the right care at the right time. I'm proud to report, with the help of some of our state senators here today and many others in the body, we were able to make meaningful progress on these goals. With the help of Senator Jacobson leading the way, we passed significant legislation to make sure Medicaid is covering more of the costs of care, so our hospitals don't have to struggle with those unsustainable reimbursement rates. And we're very close now to having that new Medicaid-directed payment program fully implemented. We established telehealth payment parity to make sure Nebraskans could get care when and where they needed it. We funded and created 200 new clinical nursing spots so more students could get in the training pipeline and more of those nursing students could train in rural areas. And we addressed the backlog of patients being unnecessarily stuck in our hospitals by improving guardianship processes and taking on other post-acute placement challenges. While these are major policy advancements, our work to preserve rural health care must continue to move forward. Today, Nebraska's rural hospitals are struggling still with lagging reimbursement rates, higher labor costs, and aggressive practices from large insurance companies and big pharma. The financial picture for Nebraska's rural hospitals, unfortunately, has not improved in recent years, and many are still struggling to operate in the black. A recent survey of our membership showed that 54% of Nebraska's rural hospitals operated at a loss in the last quarter, and the average operating margin for the calendar year of 2024 was just 1.4%, well below a sustainable margin, and 1.4%, that's the average among all rural hospitals. These tough financial conditions have forced over 20% of our hospitals to reduce or eliminate services in the last 2 years, critical services like labor and delivery and behavioral health. So where do we go from here? First, we need to make sure that our federal and state policymakers avoid deep cuts in programs like Medicaid. Medicaid is an essential building block for protecting rural hospitals and other critical services in Nebraska. Medicaid pays for 33% of labor and delivery costs in rural Nebraska, 43% of behavioral health care costs in rural Nebraska, and 44% of the cost of pediatric care in rural Nebraska. The bottom line is these services would not be sustainable in rural areas if Medicaid is cut at the state or federal level. Next, we have to take action to rein in the aggressive practices from large out-of-state insurance companies. Their prior authorizations and other restrictive practices delay care to patients when they need it and drive up the administrative burdens to healthcare providers. While our rural hospitals here in the state are struggling to keep their services open, we see commercial insurers report profits in the tens of billions of dollars. And finally, we must push back against big pharma to protect our 340B community benefits program, which sustains rural services like nursing homes, assisted living, wellness programs, and chronic disease management. While pharma is fighting across the country to halt these programs and boost their already robust bottom lines, we're going to join, with Senator Hardin's leadership, join many other states in standing up to them. Soon you're going to hear from 3 of our outstanding hospital leaders here today. Arlen Johnson, the CEO of Howard County Medical Center in St. Paul, Laura Gamble, the CEO of Pender Community Hospital in Pender, Nebraska, and Dr. Dan DeFries, President at CHI Health St. Mary's Hospital in Nebraska City. They'll tell you about the challenges they're facing in their communities and how these policy initiatives can help going forward. Then you're going to hear from a couple of our legislative leaders on the critical issues that they're going to be stepping forward on this session. But before we hear from these folks, I'd like to introduce our partner on the Roadmap to Strong Rural Health Care, Jed Hansen, the Executive Director of the Rural Health Care Association. Jed.
Thanks, Jeremy. Well, good morning, and thank you for joining us today. I'm Jed Hansen, Executive Director of Nebraska's Rural Health Association. I'm honored to stand here with the Hospital Association and Rural Hospital and elected leaders behind me to unveil the 25-26 Nebraska Rural Roadmap. 2 years ago, we stood at this very rotunda to lay out a vision for better care and stronger health care across our state. And today, we renew that call to action to protect and strengthen trusted local health care for rural Nebraskans. As Jeremy mentioned, we've achieved some significant successes through the foundation of our last roadmap, from implementing the Medicaid-directed payment system to advancing telehealth initiatives and passing the rural emergency hospital model. We've made meaningful progress. Additionally, the Nebraska Rural Health Association led efforts to expand veterans' access to care through the VA EPS program and modernization of operations for rural health clinics. But despite these successes, the challenges facing our rural hospitals and clinics remain urgent. Over half of our critical access hospitals reported negative financials at the end of last year, and approximately 10% face an ongoing and imminent threat of closure. In short, rural health care is on life support without action. But despite these successes, the challenges facing, we must act to protect rural health care through vital programs like 340B and reduce the burdens created by restrictive practices from pharmacy benefit managers and Medicare Advantage plans. The 340B program has been a lifeline for rural hospitals and clinics. For decades, it's enabled hospitals to purchase medications at reduced prices and reinvest those savings back into their communities. Thanks to 340B, Nebraska's rural hospitals have been able to fund essential services like mental health care, maternal health, and chronic disease management programs, services that would otherwise be financially unsustainable. Moreover, the 340B program supports rural pharmacies, ensuring access to both medications and skilled professionals for the future. Unfortunately, these critical programs are under attack by Big Pharma. Protecting 340B is not just about discounted medications. It's about saving lives and preserving access to care in underserved rural areas. We look forward to working with Senator Hardin and other leaders this session to pass legislation that safeguards 340B and ensures the sustainability of trusted local health care in rural Nebraska. Next, we must address harmful practices of pharmacy benefit managers. PBMs were originally intended to manage prescription drug benefits and control costs. However, they've grown into powerful entities that control how medications are accessed and priced. Their practices, like white bagging, where medications are shipped to hospitals rather than procured locally, create dangerous delays, increase liability and financial strain, and overburden our hospitals. PBMs have prioritized profits over patients for far too long, and it's time for Nebraska to demand transparency and accountability with regulating PBMs. I'd like to thank Senator Jacobson for his leadership on this one. Finally, as a nurse practitioner, I want to highlight the issue of prior authorizations. These processes, implemented under the veil of cost control, often result in delayed and denied care for patients, while generating robust profits for insurers. I've seen firsthand how arbitrary denials of basic medications and diagnostics cause frustration and hardship for patients. The administrative burden of prior authorization is, quite frankly, overwhelming. Providers spend hours navigating bureaucratic red tape instead of focusing on patient care. Worse yet, delays in care can lead to devastating outcomes. Nationally, 78% of physicians report altering care plans, and 24% report adverse events, including hospitalization and death due to prior authorizations. Prior authorizations don't just burden our providers, they harm the very people that we're here to serve. But Nebraska has an opportunity to lead the way by reforming prior authorization processes, regulating PBMs, and protecting the 340B program, we can ensure that rural Nebraskans receive the care they need when they need it. Because when we prioritize strong rural health, we build the foundation for a strong rural Nebraska. This roadmap is our path forward, a path that prioritizes people over profits, access over obstacles, and health care over red tape. Together, we can make a difference. Now I'd like to introduce you to three exceptional leaders from our rural hospitals, Arlen Johnson, Laura Gamble, and Dr. Dan DeFries, who will share their perspectives on the critical challenges facing rural healthcare today, including those mentioned like white bagging, the 340B program, and prior authorizations. Thank you.
Okay. Good morning. Again, my name is Arlen Johnson. I'm the CEO at Howard County Medical Center in St. Paul, Nebraska, 25 miles north of Grand Island. So let's talk about our path that we've taken at Howard County Medical Center. We made a decision a few years ago, my board, myself, and my medical staff, that we were going to treat people to get healthier, not just treat them when they're sick. But those things take a lot of resources and things that we were going to do. We started out a chronic care management program when nobody else was doing it. Now it's 5 people strong. We started out with 4 providers in our clinic. Now we have 9. And these things, we keep growing and bringing people to the table and giving them opportunities to improve their health. This year we built a wellness center, 17,000 square feet, indoor pool, walking track, all our therapy services moved there, all through donated dollars in our community, and how our community is totally committed to us being successful. And the other things that you think, everybody that walks in our door, we are going to make a mission that anything they have done in our facility will have a pre-authorization, just because we feel like that'll make the process better for them. Things will be getting paid for that can be, and then it'll just be a smoother situation for any patient that walks into our facility. I tell people we are a primary care facility that has the ability to keep people overnight. We're a 10-bed hospital. We are unfortunately not doing OB services anymore because of the lack of numbers, and we just didn't feel like we were as good at it, but we had to walk away from that service. But there's other things that we are trying to promote. We have 5 mental health providers within our facility. These give my primary care physicians tools to improve the health of people, because we all know that mental health is top priority of things like chronic conditions that keep growing and growing. If we can help improve people's mental health, we'll be really stepping forward in that area. So going forward, what do we need? We need to make sure that our reimbursement models are fair and they bring dollars to the table for the services that we do. You know, everybody says critical access, you get paid costs. Well, unfortunately, we haven't been paid costs for quite a few years. It's 98%. There's been a 2% sequestration for quite some time. And that's just allowable costs. I think we get all caught up in, oh, you get your costs back, allowable costs, and that's not everything that walks through the door. Think about me as an employer in Howard County, the biggest employer in Howard County. We put $500,000 on the street every 2 weeks to pay taxes, buy homes, buy cars, buy food from the local grocery store, all those things. We are committed to our community and what we can do for them. That wellness center was part of that. It's a 24-hour workout center that can be bought memberships. The people in our chronic care management program get it for free. And it's all about health improvement. It's not about curing sickness. It's about getting them well before they get sick. So we're committed to this, but we need 340B. That was the reason I was able to put together a chronic care management program like we did, as robust as it is. Now we're in 3 different accountable care organizations, one with Medicare, one with Blue Cross, and one with Medicaid. Medicaid's very important to that. People that we walk through that system, and Nebraska took a step forward and advanced that. We have a bigger Medicaid situation than a lot of states do. And if you look at the states that are successful financially, it's because they expanded Medicaid. And we appreciate what the senators have done to support us in that situation. Now, it's our job to be out there in the public, but like I said, we just need fair models, fair reimbursement, continue to keep 340B viable. Our partnership with our local pharmacy keeps that pharmacy going. That's our only partner, but it's very viable for us. So I look forward to going forward, but I feel like the place that makes the biggest decisions for us is right here in this building. And I wanted to be here today to talk about what we're trying to do. We aren't just waiting for things to happen. We're out there being aggressive, but we need the financial support that we deserve from that standpoint. Thank you.
Hello, my name is Laura Gamble, and I'm the CEO at Pender Community Hospital in Pender, Nebraska. We are a small hospital that cares for a large district in northeast Nebraska, and we're very proud of that. I've been in rural health care practically my entire life in various positions, as I am also a nurse. I am very passionate about rural health care in general, but specifically how it affects all of the residents in northeast Nebraska. I don't have any fancy numbers for you today. I don't have line graphs. I don't have charts, anything like that. You just got me, and I'm here to speak from my heart. In order to give top-notch care and provide extra services in the community we have to ensure that Medicaid and 340B programs are protected. These programs have allowed Pender Community Hospital District to care for patients that otherwise would have to go elsewhere for their care, or just not receive the care at all. We also need to stop or regulate the unnecessary amount of work and restrictions that come with prior authorizations. The time and effort that it takes to get our patients the care that they need is frustrating for everyone, and it's only getting worse. Without programs such as Medicaid or 340B, we would not be able to deliver the 116 babies a year, more than any other hospital per capita in the state of Nebraska. When other hospitals have stopped delivering babies, Pender Community Hospital District has committed to continue to provide much-needed service for the area. This is something that our staff and our providers are very proud of, but at the same time, the service does not pay the bills. And more often, this is a loss for us financially. We just had our New Year's baby, and we want to continue to feel the joy of bringing a new life into the world in a new year, along with every other baby that we deliver. Without Medicaid or the 340B program, Pender Community Hospital would not be able to offer child care services through our Child Developmental Center, or care for the elderly through our assisted living program. As you are all aware, there are less and less places for our elderly patients to go when they need care. I have another birthday coming up this week, and it's really starting to hit me hard. At Pender Community Hospital, we are lucky we have a board that understands the significance of providing these extra services, as we already start our budget with a loss in these areas, and that is not something a board wants to see. There are so many other things that Pender Community Hospital District and other hospitals in northeast Nebraska do for the rural patients on a daily basis that is not being reimbursed or goes without notice. It is only going to get harder due to decreases in reimbursement, tighter restrictions on prior auths, and in general, just having to pay more for staffing and for supplies. We need these programs to help sustain the life of our community, which is the local critical access hospital. For those of you who live in rural health or in the rural area, you know what I'm talking about. And for those that don't, you just need to go to a rural town and you'll see what I mean. I am asking today that when it comes to protecting Medicaid and 340B, that you think of all of us in rural Nebraska hospitals and look at where we are trying to accomplish, look at what we're trying to accomplish and how hard it has become. Many of us are just trying to survive. Sustaining these programs can help with that. Thank you for your time and your support.
Good morning, everybody. My name is Dan DeFries. I am the president of CHI Health St. Mary's Hospital in Nebraska City. And I'd like to thank Jeremy and Jed for this opportunity to talk about rural health care. I've been in rural health care now for almost 30 years, a lot of it as a physician and now as the president of a rural hospital. And I'm awe-inspired when I hear the work that my colleagues are doing around the state to help provide rural health care. There was a statement in the Rural Health Care Roadmap that particularly caught my attention, and that is wherever the patients, wherever they are, deserve equal access to health care. And that struck me as very important. We spent a lot of time and a lot of effort trying to make that happen. I see this rural roadmap as a big puzzle with different sized pieces to that. And my colleagues have addressed several of those pieces already. But I would like to address the puzzle piece of PBMs and pharmacies. In Nebraska City at St. Mary's, we have made an effort to step up our program for infusions, particularly in oncology, to be able to provide local cancer care and all types of infusion care for our patients in the area. One thing we've seen more recently happen and crop up to us is the process of white bagging. And white bagging means that a provider suggests a treatment that might be an infusion or an injection. The patient then finds out from their insurance company that they have to get it from a specialty pharmacy based on the insurance company's rules. That means a third-party pharmacy is providing that medication, a lot of times sending it to our hospital for us to give. Obviously, that's fraught with concerns about delays in care, and we've seen delays in care when medications have not arrived on time. We've also seen concerns with how they were delivered. We are to take these medications and then provide them to the patients, and not knowing where exactly they came from and where they have been. So obviously there are safety concerns in there. We do this for the benefit of our patients, but obviously there are concerns in there. We would like to be able to provide those medications ourselves. The other aspect is prior authorization. We have now hired 4 additional people to take on our prior authorization process for our hospital. That may not sound like much, but for a rural hospital, that's a lot. 2 of those are RNs that could potentially be providing care elsewhere, but are working on prior authorizations. So this piece of this puzzle for the roadmap is just only part of that. We have improved several huge pieces to the thanks of our legislators. The Medicaid provider payment process helps us stabilize our finances, and as Jeremy well laid out, financial issues in rural health and rural hospitals is a big concern. So thank you to our legislators for that. And we look forward to working with them on all of these processes in the future. We have great support. We have a wonderful state with wonderful hospitals. We can work on this and do this together and improve that access that we all deserve. So thank you.
Thank you to our hospital leaders for sharing their insights and what's going on in their communities. Obviously, each one has a unique situation, and they're doing the best they can with the resources, the staffing they have to provide that exceptional level of care. Now I guess we'll go maybe east to west here across the state and invite up first a great champion for us this last year in the legislature and really a leader on health policy in the legislature, Senator Mike Jacobson.
Well, thank you, Jeremy. It's not often that I'm referred to as an Eastern senator, but when I walk around with Senator Hardin, I am an Eastern senator because he's definitely out west. But I've really been pleased to work with him and looking forward to work with him this next year as he works on the 304B program. That's my understanding. He'll be bringing a bill on that, and I'll let him talk about it. I've been fortunate that I've served on the board of Great Plains Health in North Platte for the last several years. It's been quite an education. I've been able to see firsthand the challenges that hospitals deal with. We're fortunate that we've got about a 100-mile radius where you're going to not have a hospital of the size of Great Plains Health. But yet, as I look across my district, there are a number of rural areas that need care. And as you know, if you don't have your health, you really don't have much. And it's a critical need, particularly in rural areas. It's a problem throughout the state, particularly when you look in the metro areas when you find that you can't afford health care. And I think that's one of the things we've really tried to work with when you start talking about Medicaid dollars. The bill I carried last year was LB 1087, which really accessed over $1 billion of federal funds to help supplement the Medicaid payments for hospitals. This coming year, I plan to work with the Nebraska Medical Association to work on a companion bill that won't be as robust, but again, a federal program that would allow higher reimbursements for doctors and other practitioners directly. So I'm hopeful that will be find traction and move it forward. I think, as Jeremy indicated, LB 1087 is about to get finalized with final approvals from CMS, and so our hospitals will start seeing the benefits from those dollars. I can tell you, as I look across rural Nebraska, certainly out in my area of the state where North Platte is, that there are hospitals that are really struggling. And frankly, I think without 1087 and the additional Medicaid reimbursements, they would be closing. And as we close those hospitals, we lose the maternity benefits, we lose all of these other benefits that are there. People are traveling a great distance in rural Nebraska to get to the existing hospitals. They close, it becomes more and more critical for them to try to get further. So I'm a big supporter of health care. I believe we've got to find cost-effective ways to be able to fund that. Hopefully we can access more federal dollars that will help supplement what we're doing. But I have seen firsthand how important this is, and I will continue to work as we move forward to support the hospitals across the state to the extent that we can. Thank you.
Senator Jacobson. We're really lucky to have folks like Senator Jacobson who serve on the board of his hospital and are very knowledgeable about these issues, and Senator Hardin, who's going to come up and talk about the 340B program. He has a whole career wealth of experience in healthcare and brings a lot to the legislature on these topics. Senator Hardin.
Let me connect the dots for you between those snazzy commercials you see on TV about a drug, not an over-the-counter drug, but something whose name you can't remember, but it does sound like a very slick advertising crew put the name of that drug out there. Connect that dot over to rural hospitals for you. That fancy commercial you're watching is what we in the industry call a Tier 4 drug. The average Tier 4 drug in 2023, we don't really have all of the numbers out yet for 2024 since the paint is still drying on 2024, but in 2023 the average Red Book retail value of a Tier 4 drug in America was $257,000 for the average for the year. Who can afford that? Short answer, no one. And so how does that work? Well, obviously pharmaceutical companies are spending a lot of money on research and development, and when they finally get one that grabs and goes, it's got an expensive price tag on it. Well, there's discounts, and that's where the PBMs, the pharmacy benefits managers, come in with not one, but up to 7 different discount programs per drug. And that's a whole other issue that's been mentioned before, but let me connect that fancy commercial to the local hospital. At Regional West, in my home community, that 340B portion is $6 million a year. That's what it means to my hometown hospital. So as Jed was saying just a little while ago, 1.4% is the average margin of these hospitals. Now what the heck is 340B? In the 1990s, Congress passed a bill into law. Guess what it was called? 340B. This is fascinating because Congress passed that, not the state legislatures. And so it's a little bit from our position for Senator Jacobson, myself, and our cohorts in here, it's like holding on to a giant fire hose somewhere in the middle. You're not directing where that water goes to fight the fire, but you're hanging on and getting thrashed about by the giant hose. We didn't pass 340B in that chamber, but we do have to essentially approve the ability to keep passing those discounts and so forth on to the 2/3 of the hospitals in Nebraska that rely on them, as well as the specialty centers. You know, those snazzy drugs, most of the time those really snazzy drugs probably are not a part of those pharmaceutical lists, okay? But it is drugs from the past that basically Congress said, let's put a thumb in the back of the pharmaceutical companies and force them to provide those drugs at a discount. That's what 340B accomplishes. Discounts for 2/3 of the hospitals in Nebraska, obviously predominantly rural hospitals. And it's not just the little rural hospitals. UNMC relies on this. So does Boys Town. And we're also seeing that for specialty pharmacies also. So that world is connected. While we don't have the ability to change the percentages, frankly, we need to have Congress step up and remodel 340B. It was put together a long time ago, hasn't really kept up with the times, but in the meantime, those of us out here in the middle of the country need to essentially take this program, move it forward. What this last iteration of 340B was about was the pharmaceutical companies wanted to put constraints on the number of places where you could actually get those drugs at that discount. They wanted to put the squeeze on where you could get the supply and demand fulfilled. So I will be bringing 340B again this year, and we're hopefully going to shepherd it across the line. It just means that much to our local hospitals. So I really thank Jeremy for his leadership in helping to steward this for our rural hospitals. We desperately need it.
All right. Well, you've heard, the core issues that we've laid out in the rural roadmap. There are other issues in there, important issues like EMS, more work to preserve specifically maternal services in rural Nebraska. But these issues, as Dr. DeFries did a great discussion of the puzzle pieces. We've got to get more pieces of the puzzle together this session here in the legislature, and also in the rural roadmap. We have a federal focus in there too. There's going to be a lot of discussion in Washington, D.C. about reforming health care, and we're going to be very vocal about what we need to do to avoid deep cuts out there that ultimately will trickle down to Nebraska's rural communities if Medicaid and Medicare are substantially cut. The 1.4% margin that our rural hospitals are running can't take much more of a cut if you want to keep hospitals open in rural areas. So with that, I'll take any questions that folks have. Yeah.
Just a clarifying question, I think for Jed. In the press release, it said 41% of rural hospitals are at risk of closing. In your remarks, you said 10. Can you clarify?
Yeah, there are different metrics that we look at for potential for closure. The statistic in the press release was 41%, and based off of historical data, that percentage of our rural hospitals, about 24, are at risk for closure if trends continue financially for them. When I'm talking about 10%, we have about 6 hospitals in our state that, if the winds blow a different direction, there could be a closure. And so we have kind of, to use an analogy, you have a sick patient in the hospital, and you have an ICU patient. So 40% are kind of a med surge, and 10% are ICU. Yeah.
Any other questions? Andrew?
Does any of the legislation have, an A bill attached to it? Passed to it?
So we don't think any of the insurance reform, 340B reform would, and I believe Senator Jacobson took off, but I think the concept that he has also would not. So this year, with 1087 last year, typically as a hospital association, we would come in every 2 years and ask the state for more general funds into Medicaid provider rates. With 1087 just about to get launched, hopefully within the next couple weeks from CMS. We certainly are not coming back this session. It may be several sessions before we come back for general fund provider rates for hospitals at least. So the bulk of our agenda, I would say that no, there are no A bills this year. Yeah.
What can you actually do for prior authorization issues? What is there legislation, rules?
Yeah.
How can you fix that problem?
Yeah, so some of the things that are contemplated that would likely be in a piece of legislation are setting the number of days that they have to respond, tightening that up, making process more electronic as opposed to paper. We have some insurers that still want stuff faxed to them, which is just absolutely ridiculous in this day and age. And then one thing that we think is important is if you're going to make a specialist be on the phone to say why in their medical judgment a patient deserves or needs a certain service, you need, as an insurance company, to have a similar specialist on the phone. We've heard nephrologists or neurologists on the phone with dentists telling a dentist why a neuro patient, for example, needs a specific treatment, and a dentist, no offense to dentists and their medical training, but they certainly aren't a specialist in that. So that's another area that I think we need to push hard on to make sure that if you're making our hospitals spend their time with their specialists, you need to have somebody of equal educational background and medical decision-making capacity.
I guess to kind of follow on with that, I guess what would the legislative fix be for a white bagging situation?
Yeah, on white bagging, it's just putting in restrictions about how and when they could do that process. So Senator Jacobson often has a great analogy about if white bagging is the equivalent. If I have a broken automobile, I bring my part to the mechanic. Maybe it's not even a new part. Maybe it's a used part. We don't know where the part came from. The mechanic fixes it, and if something goes wrong, I'm not going to pay him any extra to use my part. And if something goes wrong, it's on him. It's not on me and my part that I brought. That's the equivalent of white bagging. So we can simply, in statute, put in restrictions on the PBMs from going forward with that process, or maybe setting some parameters where they can use it in very narrow situations.
Just a big picture here. I mean, if you don't fix this, what's the impact of trying to encourage people to move out to rural areas,
Yeah.
for businesses to move to rural areas?
Yeah, I think, it isn't lost on, I don't think, anybody that when they hear or see rural hospitals, maybe not, we do have some at risk of closure. We now have the REH model, which allows, like in Friend, Nebraska, where they were able to shut down their inpatient beds but maintain emergency. So maybe we don't lose hospitals completely, but they start to shed services, just like Arlen, had to recently with labor and delivery. And I can't imagine if you're a young person wanting to start a family that gives you a lot of confidence. Now, Arlen's folks are maybe close enough to Grand Island to get care, but if you're, 70 miles away from the nearest hospital that's delivering, or even further, it is a drain on rural Nebraska to recruit people out there. And we know that with most of our counties in the state that have hospitals, the hospitals are the biggest employer. So if you want to keep that economic engine going in those counties, you've got to keep these rural hospitals strong. And there isn't one silver bullet. That's why there's a lot of complex policy here in the roadmap. Some of these take a lot of explaining to get people to understand them, but again, back to Dr. DeFries's analogy, we got to put more pieces of the puzzle together.
Is it kind of like a vicious cycle, if you will? So like you're losing people because of the funding isn't there. They're going to bigger cities. They have to get transferred to bigger cities,
Yeah.
which is then, again, causing them to lose money because they're not getting that money from caring for that patient. So is there ever going to be a way to stop this vicious cycle before it ends up crashing?
Any of our hospital folks want to take that one? No. Well, I think it's putting these policy pieces in place. Ultimately, care can't be sustained if you don't have a sustainable funding mechanism, and that's ultimately what we're trying to build here. It feels like we take a step forward with, the Medicaid provider rate piece, which, some of our hospitals, not our critical access, but some of our kind of mid-sized rural hospitals were getting reimbursed as low as 38 cents on the cost of care. They were losing so much money on it. So that was a step forward. Well, at the same time, now we're facing over probably really since COVID, much more aggressive practices on the private insurance side, whether that be through commercial plans or Medicare Advantage. So it's a constant battle. It keeps us all very busy here trying to push forward with policy that ultimately we just want to get to that sustainable funding that can keep services open.
Yeah, please. Yeah.
In response to the question about the vicious cycle of, between bigger hospitals and smaller hospitals, we've put a lot of efforts in, my colleagues and myself, in our smaller hospitals, to be able to keep people in our small hospitals, both as an inpatient, as well as I mentioned, like infusion services and that. So having these mechanisms in place to reimburse us appropriately, allowing telehealth parity, the things that we've worked on will help us keep people at home, taking the pressure off of our bigger hospitals who are already overrun with people for a variety of reasons. So it is a vicious cycle, but if we can keep more care at home by supporting the roadmap and the things that do that to keep us viable, we'll be able to balance that better instead of overwhelming our hospitals. We can do a lot. We have talented nurses and talented physicians. We have technology now we didn't have, well, I was doing primary care even 10, 15 years ago. So that is one of the solutions, to be able to keep that care at home by supporting our rural hospitals. Does that make sense?
I might add just a little bit. We spend a lot of time across our state in our rural communities, and there are some factors that really contribute to a vibrant rural community. Having a good school system in place, having really good health care, and then just a little bit of culture in that community. And how do we stop that vicious cycle is that we have to start telling the positive stories of rural. We have to be able to focus on the things that all of these three leaders are a part of. They're all doing some really unique, wonderful things in their communities. We're seeing a little bit of a resurgence in some areas as we continue to see housing pressure in major metropolitan areas, and then as we're looking at how telecommuting is becoming more feasible for many. Rural can be a really great place to take that family, and if you've got good schools, if you've got some good health care, and if you've got a little bit of culture. So I think telling the positive story of rural is how we flip that cycle, and making sure that we're doing a good job selling that. there is a lot of concern in how we make this sustainable today, but there's also a lot of really good things that take place across Nebraska.
Do you anticipate if everything goes positively, you get what you want, and you're getting that funding, that there will be a resurgence in some services that may have been lost due to a lack of funding?
Yeah, that's a really great question, and I'll give a couple of examples in Nebraska of where that positive momentum has been taking place. A community like Grand Island, where 20 years ago was statistically considered rural and today is not technically rural. So we can't look at Grand Island in any of the successes that we have, but talk about robust medical services. You look at several different school districts in town, and you look at the culture and infusion that's taking place there. Kearney is on a trajectory for that. In the far northeast corner of the state, South Sioux City is part of the Sioux City Metro plex that is no longer considered rural. So there are successes out there, and depending on the definition of rural, there are successes that we can have. And so do I anticipate that, yeah, if we can stabilize rural healthcare, if we can bring our attention towards some of those other intangibles like rural housing, like child care along with health care, yeah, I think it's very possible that there's a bright future for Nebraska's rural communities.
Jeremy, can you get me hold of that B-roll
Oh.
again? So we can get a nice shot.
Need some
of
B-roll?
that. Yeah,
All right, I'll
quick and
pretend I'm
drop
still
me.
talking here, so it looks
Yeah,
like
sorry.
I'm not just standing there with the, there you go. Well, thank you all for joining us. Thank you. Oh, you still, okay, yeah, all right, all right. This is,
You're not a very good hand model.
no, I know, sorry, I didn't lotion today, Andrew.
Thank you.
Thank you. Thanks, all right, thanks, everyone.